Hello, this is Wen Murphy, and I'm speaking on Week 12, Case Study 1, doing a presentation on skin burns. This is being recorded on April 5th, 2015 for the Advanced Pathophysiology course at Simmons College of Nursing and Health Sciences for their Family Nurse Practice program. My objective today is basically to review Case Study 1 for you and provide evidence-based practice guidelines for the care of burns and explain the pathophysiology behind burns. I'll be reviewing the normal structure and functions of the skin, specifically from a cellular composition, and look at the role and purposes of layers, the epidermis, the dermis, and the hypodermis, discuss degrees and depths of skin, first degree, second degree, and third degree, and why we no longer actually refer to them as degrees, and then why depth matters. In other words, how burns affect the skin based on how deep they go. We'll also look at the relationship between TBSA and outcomes. We'll have some practice in estimating sizes and look at mortality as it relates to the box score, and then discuss briefly on the morbidity of burns. And then look at why fluid matters. We'll be discussing Parkland and modified Brook and when you might use one over the other. And then the role of ventilation, specifically as it relates to our case study and airway management in burns. And then look at burn shock from a local and systemic perspective, as well as burn infections from a local and systemic infection. So this is our standard pathophysiology diagram of skin. Skin is the largest organ of the body and consists of the body's entire outer layer. I know that we learned that the liver was the largest organ in the body, but I still am adamant that the skin is actually the largest organ of the body. It is an organ system, right? It regulates temperature, provides protection against infection and internal structures of the body, such as muscle and bone. And the skin prevents loss of body fluid, housing nervous structures, communicating pressure, pain, temperature, and touch. It also contains glands, pores, and hair that function to regulate the body temperature. So we have a tall order for this little thin layer that surrounds the outside of our body from the outside world. When we look at skin cells, there are basically three types, but they are all epithelial, right? If you look at epithelial cells in our bodies, we have either simple or we have stratified. And the easiest way to remember which one the skin cells are, they're layers, so they are all stratified, right? So we have stratified squamous, stratified cuboidal, and stratified columnar. They're also all the stratified are also on the outside of the body, whereas the simple epithelial cells are on the inside. That's the other way to kind of distinguish the two. So these are the ones that we're looking at when we talk about skin cells. The primary functions, again, of skin are to provide protection, permit sensation, allow thermoregulation, control evaporation, provide storage and synthesis of lipids and water, absorb nutrients like oxygen, nitrogen, carbon dioxide, and vitamin D, and retain nutrients, specifically providing water resistance and emollients. Okay, so lots of functions for our skin. There are three layers. We have the epidermis, which is basically 5 very, very tiny layers. So if we were to look at that, it's this layer right in here. Okay. Then we have the dermis, which is that middle layer, which is right in here. Okay, and that's where we get sensation and endocrine and exocrine functions and our vitamin D synthesis, the nutrients and all of that. And then we have our hypodermis or subcutaneous fat layer, which is on the bottom, and that provides cushion and also a layer for the vascular systems. Very important. So let's take a look at the epidermis. It basically 5 layers. They're very thin but very tough, and it is the outer layer of our skin. Keratinocytes are migrating from the basement membrane and gradually shed. It is the outermost portion of the stratum corneum, which is waterproof, and when it is undamaged, it prevents bacteria, viruses, and other foreign substances from entering the cells. What I want to bring to your attention are basically within this epidermis we have melanocytes, They produce melanin or pigmentation, skin coloring, and they also filter out UVA and UVB rays. Then we have the Langerhans cells, and these are part of the skin's immune system. When they become hyperactive or damaged, they can play a role in developing skin allergies. And then the Merkel cells communicate sensation. It's a very, very light pressure sensation, okay? So if you were to take this from the perspective of a burn patient, if you no longer had Merkel cells, you would no longer be able to sense light pressure or that light breeze that blows across the top of your skin. If you no longer had melanocytes or melanin, you would have hyper or hypopigmentation. And then, of course, if you lost your Langerhans cells, you lose your immune factors and your ability to be resistant to skin allergies. So again, burn patients tend to have very, very sensitive skin and or are very susceptible to infection. So let's take a closer look at the dermis, that middle layer of our skin, right? It is composed of fibrous and elastic tissue, primarily collagen, elastin, and fibrillin. It provides stretchability to the skin. As we age, of course, we lose collagen and elastin, which makes our skin even stretchier. And it contains nerve endings, sweat glands, oil glands, hair follicles, blood vessels, and it provides pain, touch, pressure, and temperature sensations. The thing that I want to draw your attention to is this sentence right here. Basically, hair follicles provide temperature regulation, but more pertinent to burns, they contain stem cells, which are capable of regenerating epithelial cells and skin growth. Very important, okay, when we look at burns and the depth of a burn. All right, so let me bring up my highlighter again. I want you, if we look at the dermis, we're going to try to separate that into two layers. So we have the upper layer and we have the bottom layer. All right, notice what is in the upper layer here. What basically cuts across that upper layer is all of our touch receptors, our pain receptors, our cold and our heat receptors, and even our capillaries. What is in our bottom layer is the blood vessels, the deep pressure receptor, and the root of our hair follicle, as well as our sweat gland. All right, this all plays a role in terms of when we look at burns and burn survivors and what might be affected in terms of the role and function of their skin. Okay, so keep that in mind as we move forward. And then as we look at the hypodermis, we're basically at that bottom layer, which is all fat, adipose tissue. Some of us have more than others. It contains connective fibers. It insulates the body from heat and cold, and it provides padding and protection. The thing to remember is that every part of our skin does have and contain the hypodermis, which is that adipose tissue. However, based on its location, it may be thick or thin. For instance, eyelids have a very minuscule layer, while our abdomen has layers that can be several inches thick. In understanding the skin, and as it relates to the burn, what we're looking at is once that skin becomes damaged, the body is susceptible to infection and is at an increased risk for multi-organ system failures. Most small burns are usually treated in acute care and emergency room settings, which is the primary setting for the majority of nurse practitioners. And as future nurse practitioners, you will probably encounter a couple of burns in your career. Burns are classified by depth, size, and mechanism of injury. What I want you to remember as you work with burns is that it can take up to 3 days or 72 hours for a burn to fully declare its depth and the size of its injury. Okay, that becomes very important. When we talk about burns in the old days, and many of our old timers still do, we used to say 1st degree, 2nd degree, and 3rd degree. That's how we used to classify them. Okay, but we no longer do that. We now classify them based on depth. So we have superficial, which used to be 1st degree, so that's that epidermis layer. And then this is the reason we got rid of second degree, because we have two layers in that dermis area, right? So we have the superficial partial thickness, which is that top part of the dermis, and then we have the deep partial thickness, which is the bottom part of the dermis. And then of course third degree is really full thickness. So that's how thickness and depth relate to burns. So what are you looking at if you look at a burn? Well, here's some things that I want you to take away. When you're looking at a burn, what you want to see is how deep does it go? And is it wet? So is the fluid layer involved? Are the hair follicles intact? So those are some of the simple questions you want to ask yourself. If we were to look at this burn right here, you can kind of see where this top layer, the stratum corneum layer, has kind of been sheared away. But all of the hair follicles, if you look really closely, are still very much intact. And it's a very dry wound, meaning that we probably have not hit the dermis layer, so we are still in that epidermal layer. We've just taken off that first stratum corneum layer. All right, so we're going to call this a superficial burn. All right, if we were to look at the skin diagram, the area that is affected is basically this stratum corneum layer right here, and maybe some of the stratum lucidum, but really the granulosum area is very much intact. This one, first off, you notice that it's very wet and shiny. You can kind of see where the dermal layer has been sheared. This is what we call pretty much a degloving, right along here, when we've got that definite demarcation between the epidermis and the dermis, right? So that's been pretty much sheared. I have little red areas here which tell me that I've got the capillary bed involved. I can still see lots of hair follicles, right? If I look closely, I can see some hair follicles in this area. This area probably has some hair follicles if I looked even closer. So I know I've reached beyond the epidermal layer. I've hit a very wet layer, and so my indication is that I'm in the superficial partial thickness layer. If I were to look at that from a skin diagram, the area that I'm talking about basically is this area right here. Now remember, this area contains all of those nerve and sensation endings. So it's going to be an extremely painful burn. Again, this is a superficial partial thickness burn. It's a couple of days older, so it's not quite as wet, looks dry, but again, you can see if you look pretty closely that we probably have all of our hair follicles in place. This burn goes a little deeper. The areas that I want to highlight are right in this area right here, this area right there. This is basically what we call eschar. It's not going to come off without being scraped with a curette or a Norsen debrider or even a surgical knife, right? This area here where it's nice and white and dry tells me that I've gone deep into the dermis, right? I do not see any fat layer, so I know I haven't hit full thickness. This white area, shiny, still probably pretty deep. The lighter pink areas are probably superficial dermal, right? So right in here, probably the top part of the dermis is affected. So I'm going to call that a deep dermal partial thickness because the majority of it is pretty deep. All right, and when we look at this one on the skin layer, what we're looking at right here is this layer right there. So hair follicles have been damaged, sweat glands are probably gone. We've got capillary beds that are probably damaged. So some pretty significant deep burns. More than likely it's going to scar. I like this picture because it basically demonstrates all the different layers into the dermal, right? So you have your epidermis layer right here kind of lining along the edges. And then you see this layer right here, which is that top part of the dermis, the superficial, right? So we have the superficial right there. And then we get into the deeper parts of the dermis. And we might even be into some of the fatty areas right in there, right? So that might even actually go to full thickness. But for the most part, we're going to say this is a deep dermal partial thickness burn. This one, you're probably first glance going to say, oh, that's a superficial burn. Skin is intact. The problem with that is you have blisters. Anytime you have blisters, you know you've reached beyond the epidermal layer, right? So you've got your blisters right here, and right there, and right there. So anytime you've got blisters, you know you've reached the dermal, probably superficial. So we're going to call that superficial partial thickness. And again, if we were to look at that from a skin diagram, the majority of that burn is right here, that epidermal, all that light pink area right in here, all of this area right here, that's all epidermal, right? That's all epidermal damage. But then when we get here, we're basically in this area right here. So we've hit the fluid layer. And that is why we distinguish that as a superficial partial thickness. This one we're going to call superficial to deep dermal partial thickness. The lighter area on the right shoulder is probably deeper. And then this one, what I want to call your attention to right here is this area right here. Right there, that area right there. That is basically leather, right? So that is a full thickness burn. It is not going, it's tough. The heat has pretty much seared everything, and it's a full thickness and not going to expand. Everything has been damaged. We still got some shiny areas, so we know we're in superficial dermal areas there, and then where it's a little drier but not quite as leathery, we've got the deep dermal. So this one goes superficial and deep dermal partial thickness to full thickness. And if we were to look at it from a skin diagram, basically what is happening here is the heat has pretty much penetrated all layers of that skin and killed everything from the top all the way down to the bottom. Again, this is a full thickness with some areas of partial thickness. The problem with this burn is it's circumferential around that arm. As she gets fluid to resuscitate her, that arm will probably swell, and you may be at risk for acute compartment syndrome. So we may actually have to cut through that to help that skin expand and keep it from causing her fingers to lose circulation and then die. So why does depth matter? Well, when you're talking about superficial burns, they're going to heal on their own. It takes 3 to 14 days, and basically what's happening is that top layer is basically sloughing off. The squamous cells are being repaired and replaced, right? So you've got that area right in there, right? And remember that the squamous cells, the keratinocytes, are basically migrating from that basement membrane layer, right? This basement membrane layer, so they're migrating and they're going up. So they're just basically replacing themselves. When you have superficial partial thickness, meaning that top layer of the dermis, the papillary layer, they're going to heal within 1 to 2 weeks, and they're rarely going to scar unless you're already prone and susceptible to keloid formation. Chances are you're not going to scar because your columnar layers still are intact and your hair follicles are intact. Remember, healing occurs from the epidermal cells lining the sweat glands and the hair follicles because you've got those stem cells in there. And they're going to grow to the surface and then migrate across the surface to meet the cells from neighboring glands and follicles. Okay, so again, we're looking at that layer right in there, that middle layer right there, and it just basically sort of migrates up. When we get to the deep partial thickness burns, though, they're going to take greater than 2 weeks to heal, typically 3 and 4, sometimes 6 weeks depending on the size. Healing is only going to occur from the hair follicles if they are intact, And scarring is going to be more common because we've lost that columnar layer. All right, and it will typically be more severe. So why is that? Basically, we're looking at that deeper layer, remember, okay? And because we've lost the columnar cells, they sort of glom together to try to close. They're now default programmed to close at the top. So what happens, basically, is they will close here, but you got all this area right in here, and that's still healing. As it heals, it has nowhere to go but up. As it goes up, it forms scar tissue, creates lumps, right? It doesn't have the nice columnar layer, and so that's why we have scarring that occurs. When we get to full thickness burns, it involves the entire dermis and into the underlying fat layer. Healing occurs only from the periphery, meaning from the sides, all right? And these burns, unless they're small, are going to require excision and skin grafting, some sort of skin grafting, depending on how deep they are. Typically, we do autograft, meaning we take it from the patient's own skin, unless they are in a research project. So again, the full layer of skin is involved. It tends to heal first in the middle. By healing first in the middle and closing in from the sides, there's contraction that occurs. We then put this nice thin layer of autograft or allograft on. And what happens when we do that is basically we put a little mesh pattern here with lots of holes. And we put that on top. And just like when we had the hair follicles, what will happen is where this adheres to this layer, it will then start to fill in and close. And that's how we heal. So this becomes sort of like a scab. If it's allograft or pig skin, meaning xenograft, it will eventually lift. And our ideal, if we have enough of the hair follicles in place, is that that gives us time for the stem cells to generate and grow their own epithelial cells, right? So that's kind of what we're hoping for when we put allograft or xenograft on. So as it closes here, if it's allo or pig skin, basically it will then sort of lift off like a scab. But if it's autograft, it's actually going to take. The problem with that is that because we have this mesh pattern, let me pull it in again, because we have this mesh pattern where it's filling in here, it forms these little bumps, which are scars, right? And again, we've got all of this area right here, which is still healing and remodeling, and as it heals and remodels, it has nowhere to go but up, which is why you get scarring. But remember, you have contraction occurring as well, right? So you're losing a lot of that stretchability to your skin, and that becomes a problem as you recover. Here are examples of allo and autograft. On the right-hand side, you have an autograft. It's very thin. We usually do split thickness skin meshed grafts. The mesh is basically that fishnet pattern. And on the left, we have what looks like allograft human cadaver skin, and that looks like a full thickness. So we basically just taken the cadaver, sheared that first skin off, gone through the skin banks and tissue banks, made sure everything's good, and then we can use it on our patients. Again, what we're hoping there, even though this looks like it's a full thickness burn, what we're hoping there is we're going to give it enough time to create a good wound matrix so that we can eventually close it with an autograft. So why are burns different? Burns are basically protein that is denaturized, right? Just like you take an egg and you put it in the frying pan and the clear turns into white, you get a coagulative necrosis that occurs. So where it gets heated up, it creates coagulated tissue, the platelets aggravate, the vessels constrict, and then you get marginally perfused tissue, which basically expands the zone of damage, which is what we call the zone of stasis, because we're looking for where does it stop. and that can extend around the initial burn injury. So in that zone of stasis, the tissue is very hyperemic, meaning that it's very cherry in color and very blanchable, and tends to be inflamed. Damage to the normal epidermal barrier allows the bacterial invasion to occur, and we get external fluid loss. The other thing is the full extent of damaged layers usually takes about 3 days to manifest, which is why we call that period letting the burn declare itself. So what am I talking about? Well, in picture form, let's assume that cell gets burned. That's a nice little epithelial cell gets burned. It's just that one cell. We took the head of a needle and put it on that one skin cell. Well, what happens is that heats up, and around the edges, that heat expands. And then it goes to the cell that's next to it. And that cell also heats up and then dies. And then that heat expands to the next cell. So that's what I basically am talking about when I'm talking about the zone of stasis. So in other words, where does that damage stop? Where does it no longer heat up enough to cause cellular damage? If you were looking at that from a burn manifestation perspective, this is a burn. As you can see, it's a nice big blister. So we have a nice hot spot right there in the center where that blister formed. And you can kind of see that there's some damage on the fingers and the knuckles, but not a lot. So it looks like a pretty superficial burn, except for that nice blister there. Well, let's look at day 2. Wow, did that expand, right? So again, all the tissue that was near started dying, and the damage went further, and we get more fluid loss because the tissue membranes are disrupted. And then this is day 3. So you can kind of see back to day 1, right? And then day 3, you can kind of see how that expanded. So that's what we call by letting the burn declare itself and the zone of stasis. So if you were to look at that initial burn injury from day 1, you can kind of see that it actually is larger and deeper than we initially thought. It was definitely a superficial partial thickness. One, we don't have any scarring, but what I do want to kind of bring your attention to in this picture right here is what I call the hemosiderin staining, right? This hyperpigmentation, meaning it's darker, right? Remember those melanocytes in the epidermal cells? Well, it looks like they got damaged, which means that this patient will probably be more susceptible in those areas to UVA and UVB penetration, and therefore probably want to keep an eye on carcinomas that might form, as well as keep that very well coated in sunscreen. So TBSA and outcomes. When we look at TBSA, TBSA is total body surface area. This is calculated only for partial thickness and full thickness burns. In other words, we do not count superficial burns in our TBSA because the fluid management system of the body is not impacted. Remember, when we're in the epidermis, we don't have any fluid disruption, but once we hit the dermis, then we get fluid disruption, and that is what we're concerned about when we're talking about burns and TBSA. The 3 most common tools for estimating TBSA are the rule of 9s, the Lund-Browder chart, and the 1% hand rule. When we look at the 1% hand rule, we're looking at the burn patient's hand size and not ours. And it is important to make an accurate estimate early to determine the need for fluid resuscitation, because we start fluid resuscitation at the TBSA of 20 or greater. So here's the rule of 9s. So what we've done basically to make things simple in an ED setting or an emergency setting is tell people basically the head is 9, the arms are 9, the legs are 18, the front and the back are 18, and the perineal area and hands and feet are 1. Okay? So what does this mean? Well, the thing that most people get confused on is when you say arms are 9, they say, oh, front and back is 9 each. Wrong, okay? So when you're looking at the rule of 9s, it's very important that you remember that the whole arm is 9. All right, so if you were only going to be dealing with the front of an arm, what you're dealing with is basically 4.5. Okay, so that's just 4.5. Now, if we had the back of the arm also, then we're at 9. Okay, and remember that includes the hand. Okay, so the entire torso, the front is 18, and the back is 18. Now, legs are 18, so that means that the front of a leg is 9, and the back of a leg is 9. Okay, so I've kind of broken it down for you in each segment, and hopefully you'll be able to remember that. So that's the rule of 9s. And then when we look at the 1% hand rule, again, we're looking at the burn patient's hand size, not ours. So let's say that the backhand here on the left is my hand. If I were to use that to estimate burn percentage, I'm probably going to underestimate the size of that burn, right? Because I'm going to use less of my hands to cover the same area. But if my hand were that front hand and the backhand were the patient's hand, then I'm probably going to overestimate the burn percentage because I'm going to use more of my hands to cover the same area than the burn hands. So what we like to do is we like to actually pick the patient's hand up and use that to guesstimate the size. So you need to make sure that you use that size of the hand. Make sure you use that when you estimate, and you try to calculate and move that around the patient's body to estimate size. And remember, that's 1%. It includes the fingers, the fingertips, all the way down to the wrist. The Lund-Browder is the most specific chart. So if we take our case study, the description says he was burned on the torso and bilateral arms for a total of 42%. So let's see if this is going to be possible. So anterior trunk, we're going to assume the posterior trunk as well, and then we're going to say the upper and lower parts of each arm, as well as one hand. Now, what I want to call your attention to on this particular chart is this area right up here, right? So it is broken down by age, and based on the age, we have different numbers for different parts of the body. So a child's head is much larger in proportion to a child's trunk, whereas an adult's head is much smaller in proportion to an adult trunk. And that's why we have those distinctions, okay? And again, only the partial thickness and full thickness, which on the Lund-Browder it still says 2nd degree and 3rd degree. So if we add those numbers up, we get 36 for 2nd degree, we get 6 for 3rd degree, and we have a total of 42%. So that's probably an accurate description in terms of our case study. So if we look at this particular TBSA, what we're looking at here, both arms, front and back, 9 and 9. And then on the back we have these, what I call sparing bands, where the skin is still intact here, right? So we have these sparing bands right in here, right? So we have to subtract those from 18, all right? So if we were to do that, and you can see we include the buttocks as part of that, right? So we include that as all spared. We're going to have to then make a guesstimate. So again, this is where the 1% hand rule might come in handy. We would use that patient's hand and probably estimate about 8 hands worth for a total of 10% burn surface. So the TBSA there is 28%. It is deep partial to full thickness. Here's our guy again. Both arms, the front and half of the back, plus the face and the neck. So we have 9 and 9 for 18, front and back of the arms. We have almost half of the back, which is 9. We have the face and the neck, which is 5.5. And that gives us a total of 32.5 superficial partial thickness. You can see some areas of this left arm are still intact, but if you were to take a closer examination, you could kind of see that they actually indeed were burned, and we just need to peel that layer off. So it's very important when you're estimating TBSA, you take all the clothes off and you do an aggressive debridement. This lady is a 96-year-old who spilled hot soup in her lap. Was very frail and unable to get up very quickly, so it kind of sat in it on her pants as well. So her right anterior thigh, which is the picture on the left, is about 3 hands worth. Her buttocks are approximately 6 hands worth. That's over on the right hand side. And then it kind of seeped down in between her legs, so we have the bilateral medial thighs also affected. So our total TBSA here is 12%. Superficial to deep partial thickness. That white area on the left thigh, the left anterior thigh, actually not right, my fault, but that white area is probably a deep partial thickness or even full thickness burn. This gentleman has front and back of his arms affected. What I want to draw your attention to here is basically the axilla was spared. We still have all of our axilla hair intact, which is a very good sign. So we have the right arm front and back, and we have a lateral torso. So if we take his hands, we probably get about 3 hands worth. And then we have the right side of his face and ear, which is half of the face, which is 2.25. So we have a total of 14.25% TBSA, superficial to deep partial thickness. When you're talking about burns, we really have major mechanisms of burns. We have the flame, we have the explosion, we have basically contact or thermal in the Hawaiian Islands. That would be coral skid. On the mainland, it might be motorcycle road rash. Then we have scald burns. Remember, children and elderly folks are more likely to experience a scald burn than any other demographic. You have electrical burns, which we make a distinction between high voltage and low voltage. Low voltage is your domestic electrical sources. High voltage are your power lines. And then you have radiation burns, and those are most likely in the form of chemoradiation that's gone a little too deep, a little too fast. And then you have your chemical burns, and we're concerned about alkaline versus alkaloid, acidic. So mechanism matters. It's going to give you a clue as to the depth and the type of treatment to expect with a burn, and it's going to corroborate the story. Possible abuse concerns are what we're really focusing on there. What I want to bring your attention to basically are sock patterns and full thickness on the volar aspect of the hand and foot. Here is a classic sock pattern. This is a child that was purposely and intentionally immersed in hot water. You can kind of see a clear demarcation right here. Let me pull up my highlighter. You can see a clear demarcation right here, right? And that tells you that that child's feet were submerged into hot water. You can kind of see where we've got this degloving effect right here on the epithelial layers. That was submerged for a great deal of time or extremely hot water. So this is an immediate suspicion of child abuse pattern of a burn. The volar aspect is basically the plantar aspect and or the palmar aspect. So anytime you have a full thickness on the palm or the plantar surface, chances are somebody held that down onto a hot surface intentionally. The only other times I've seen that accidentally is, of course, when we grab for our curling irons and touch the wrong part. But we tend not to hold on to very long. So outcomes are measured by 2 factors. We look at mortality and we look at morbidity. So mortality is the likelihood of death, and morbidity is the likelihood of disability and permanent physical deformities. You have both of those concerns when you're dealing with burns. What we are great at today is keeping people alive, but we're still not so great at minimizing the morbidity aspect, the permanent disability and deformities that burns cause. Outcomes are measured, again, in mortality. What we use is a bow or box score, and that was developed in the 1960s. And basically what that is, we take the age and the TBSA, and that comes up with our mortality score. We refined that in 2010. We added inhalation points. So for inhalation injuries, we added 17. And because we've gotten really good at anti-infectives, respiratory ventilator management, and continuous renal replacement therapy for sepsis, we have basically stated that if your box score or BO score is under 125, then your chance for death is still high, but with aggressive therapy, you will probably survive. So let's take our case study. He's a 45-year-old gentleman with a 42% TBSA, and we're going to add 17 for that inhalation injury and come up with 104. Again, that's under 125, so with aggressive care and quick transport to a burn center, this patient has a high likelihood of surviving. But again, the morbidity is probably going to be high, right? So current standards of care for full thickness and deep dermal partial thickness burns still result in scarification, contraction, heteroptic ossification, which means basically the scar bands then form bone tissue, and then lifelong disabilities. Research is about 2 years away from FDA approval for what we call a skin gun process. This was developed in Australia about 15 years ago, and basically what we do is we take a small portion of the patient's own skin. We, in the operating room, separate the layers, put it in a buffer solution to stop the protein denaturation, and then we put it in a proprietary matrix of various chemokines and interleukin factors and all sorts of things, and then we basically spray it on the burn, right? So we don't have to actually use that mesh pattern, and it actually heals without a lot of scarring, and it's a pretty effective method. But again, the FDA is requiring us to do thorough research, so it's right now been approved for phase 3 study trials. I worked on a phase 2 portion of that, and then we also have a full thickness skin substitute, which we are working with. That's probably another 7 years away. That has also just gone through phase 2 trials and has now been approved for phase 3. So this is basically what I'm talking about when we talk about morbidity. Again, that skin mesh, you can kind of see that fishnet pattern and the contraction and scarification. This is a back with lots of keloid plus the skin mesh patterning. This gentleman was one of the gentlemen that was in the Rhode Island nightclub fire. He does a lot of speaking, inspirational speaking at places like Burn Congress, which is where all of our burn survivors sort of collect. He met and married another burn survivor, and they actually have a brand new, beautiful baby girl. The thing that you want to also consider is, let's say that you are a woman who has an abdominal burn and you need to have autograft on that, and then you decide you want to get pregnant. Well, guess what? Your skin is not going to stretch in its normal fashion, and chances are you're going to need surgical interception in order to allow you to grow that baby in your growing abdomen. So those are some things that we are still continuing to work on to try to make better for our burn survivors. When we look at fluid resuscitation, what we're looking at basically are 2 formulas that are approved by the ABA, the Parkland and the modified Brook. If you have superficial partial thickness burns, or you have comorbidities like kidney failure, right, or you're a child, then we're probably going to use the modified Brook formula, which is the 2 cc's per kilogram per TBSA. Otherwise, we're going to institute the Parkland formula, which uses 4 cc's per kilogram times TBSA. What this does, this formula gives us the total fluid resuscitation needed in 24 hours. What we do after we get that number is we divide it by 2, and whatever that number is what we need to be administering in the first 8 hours after a burn injury occurs. And then we give the next half in the remaining 16 hours. Okay, so if a patient receives delayed care for fluid resuscitation by more than just 1 hour, we need to take that into consideration and make it, instead of 8, divide it by whatever it's been adjusted to for the remaining amount of hours since that burn onset. So what does that mean? Basically, let's take our case study here. We've got a 42% TBSA. Let's say he's 119 kilograms, pretty big guy, and he arrives into the ED 3 hours after the burn injury. So we need to figure out what we're going to start his rate at. we get 4 times 42 times 119, 19,992 for our total fluid volume for the next 24 hours. We're going to divide that by 2, and we're going to get 99.96. So that's what we need to be giving in the first 8 hours. But remember, he came to our ED 3 hours after the initial burn injury. So now we have to take 8 minus 3 and get 5. So we're going to divide 99.96 by 5 and come up with almost 2 liters an hour for fluid. That's what we need to be giving him for the next 5 hours. Okay, and then at the 9th hour, we're going to decrease that. So if the patient received 3,000 cc's before they got to our ED, we need to take that into consideration as well. So we need to adjust the formula. So we're going to take what our first half volume was, 99.96, subtract the 3,000 that he received to come up with 69.96. Now remember, we're in the 3rd hour, so we still need to divide by 5. 69.96 by 5 gives us 1.4 liters an hour. And that's pretty much what the Parkland formula is all about. So let's talk a little bit about ventilation and airway management as it relates to our case study. Burns cause an immediate inflammation and edema process. They basically swell up within the first 60 minutes. I like to say they become our Pillsbury Dough people. They become very, very puffy. Airways are at a high risk for compromise whenever this happens. All right. There are 3 types of inhalation injury. There's chemical, carbon monoxide, and cyanide. Carbon monoxide and cyanide are 2 byproducts of the burning process, especially more prevalent in today's manufactured laminate wood flooring, as well as our IKEA types of furniture, all of our particle board, right? So all of that contains high levels of cyanide and carbon monoxide. We also have supraglottal, which basically means injury above the vocal cords, so in the mouth, the lips, anything forward, right? And then we have, and that basically is a result of direct heat and chemicals, which cause edema. And then we have the subglottal, which is below the vocal cords, and what this results in is parenchymal injuries that result in pulmonary edema. So ventilation management becomes a very critical consideration when we're dealing with burn patients, because that swelling can happen instantly. Signs and symptoms that we're looking for any compromise include soot in the mouth and nose, singed nasal hair, red or inflamed oral mucosa. So what I would do in the case of this picture here is basically you can see all the soot on the tongue and you can kind of see the singed around the edges. What I'd want to do is I'd probably want to flush that out, suction it, and then see if I can see any red or inflamed oral mucosa. You're also going to be looking for stridor, respiratory distress, hoarseness, or any change in vocal quality. And the other thing to be on the lookout for is signs of hypoxemia or hypoxia, and that manifests mostly as agitation. The thing about ventilation and airway management in burns is that we still receive too many unnecessary burn deaths because people underestimate the impact of the airway injury, and so they do not intubate soon enough. Once the swelling starts, it becomes very difficult to impossible to intubate that patient, and then we have to try to do an emergency cannulation or trach, and those typically do not do well in the field. So if in doubt, always intubate. You remember, you have about 60 minutes before that swelling kicks in to the point of irreversible closure. Maintaining airways are one of the most critical aspects of early burn care. So if you suspect a burn injury, if you have stridor, retraction, respiratory distress, or a deep facial burn, then intubate without any questions. Apply humidified oxygen. We would much rather extubate later for an unnecessary intubation than not be able to intubate at all in the first place. All right. If it is suspected but it does not meet any of the above criteria, then what the ABA would have you do is apply 100% nasal cannula oxygen, preferably face mask actually, so you could put 10 liters on, and then monitor closely for the next 24 hours. Be ready to intubate at the first sign and symptom of any respiratory change. You also want to perform a laryngoscopy and basically look for any of the inflammation signs and symptoms. So resuscitation we've gotten really good at. Our goal is to anticipate and prevent burn shock. We do not want to play catch up and treat it. Basically, if we have to do that, we've reached cell death, and cell death is not an event that is eligible for resurrection. I like to say there are no Jesus moments when we deal with burn tissue and keeping it alive, right? Everyone agrees that fluid resuscitation is the primary factor in determining survivability of burns, especially if the TBSA is greater than 20%. And our consensus formula is not set in stone. In other words, it is a guideline, and again, we use the Parkland and the modified Brook. We know that if we give high-dose vitamin C in the first 24 hours, we can actually reduce the amount of fluid that we need by 40%, and we can reduce the amount of tissue edema and water accumulation by 50%, and that leads to decreased ventilator days. The bad part of resuscitation is over-resuscitation will lead to pulmonary edema, myocardial edema, conversion of superficial into deep burns, and the need for fasciotomies in unburned limbs and abdominal compartment syndrome. Initial rates are based on accurate calculation of TBSA, and the most first responders and providers specialized in burns do not calculate accurately. Aggressive fluid resuscitation potentiates the edema and decreases the tissue perfusion. The other thing is any delay in fluid resuscitation beyond 2 hours will complicate your resuscitation and increase your complications. The ugly part is there is no agreed upon standard to the approach of resuscitation, and ABA guidelines have not been updated since 2001. Remember, what year is it? 2015. It's been 14 years since we've updated. Over-resuscitation and under-resuscitation studies provide mixed results, and Cochrane cannot agree on any standard. Resuscitation failure increases with comorbidities of inhalation injury, electrical burns, and those in whom resuscitation is delayed, and those using alcohol or illicit drugs. Okay, so the other thing is meth lab burns require 2 to 3 times more fluid. Remember, if we're giving 20 liters to our case study patient, and that patient was also in a meth lab burn, then that 20 liters turned into 40 or 60. That's a lot of fluid on board, right? Studies indicate that the gold standard of measuring urine output for adequate fluid resuscitation is also not a great indicator, because it's about a 6-hour delay in what we're putting in and what we're getting out. So burns and shock. When you deal with burns, you have the shock effect, right? So where locally we encounter cellular shock, that leads to fluid loss, which leads to the blistering. That initiates the cytokine cascade, which initiates inflammation. You also have nerve shock. Remember, our nerves are damaged. Those pain signals get traumatized and send out massive signals, which then leads to a decreased vascular resistance, which will lead into a drop in blood pressure. Our systemic effects, basically lack of proper fluid resuscitation, is the primary cause of shock in burn patients. They basically experience what we call hypovolemic shock. Hypovolemia leads to decreased blood volume. It only requires 20% loss of fluid to initiate the hypovolemic shock. Blood plasma is leaked through the inflammatory processes, the cytokine cascade, and causes intracellular edema, or third spacing, actually that's extracellular edema, in the lungs and surrounding tissues. Blood plasma is needed to maintain blood volume, and this is why we add albumin to many of our resuscitation protocols. Burns create a massive cytokine cascade response. There's an integumentary compromise, fluid loss, intracellular disruption, inflammatory processes get kicked off, which lead to edema, which lead to pulmonary compromise. Vascular compromise occurs, we get hypoperfusion, we often end up with emergency escharotomies and hypotensive shock. From an integumentary process, We get hypotension, we get low blood pressure, that leads to decreased MAP, which leads to decreased hypoperfusion of the tissues. That'll increase the depth and size of our burns. The decreased MAP also leads to altered mental function, which leads to stroke and long-term disability. Hypotensive shock is basically the end result. Let's look at the cytokine process very quickly. Basically, you have the burn, you initiate anti-inflammatory mediators. Those stimulate the monocytes and macrophages, which then create kick off the chemokines, and the neutrophils start flooding the area. And then the other thing is we have the production of nitric oxide, which leads to myocardial depression, hypotension, and a metabolic block. So let's briefly touch on burns and infection. From a local perspective, burns rarely become infected when they are properly cared for. We usually treat burns with Silvadene or a silver type product, silver nitrate. Silver has antimicrobial properties. It also promotes skin healing. It is, however, becoming overused in wound care and wound care products, and actually early studies indicate that we are developing silver-resistant microbes. If you have redness at the periphery plus pus plus a tenderness, then these are indicators of possible wound infection at the local site. Burns typically are red, inflamed, and tender, so using redness, inflammation, and tenderness as an indicator for infection is not necessarily a good sign. What you want to do is avoid taking cultures routinely for burns. Only when there are signs and symptoms of infection, which would include increased white blood counts, a temperature above 35.5, and then the presence of wound slime, especially if it's accompanied with a smell. Okay. Systemic infection, labs are not always a good indicator that you have systemic infection going on. Burn patients will experience what we call neutropenia and periods of neutropenia. So their white blood count status fluctuates, okay, because the inflammatory processes produce varying levels of white blood count, neutrophils, and all sorts of things, right? So they tend to be elevated, neutrophils tend to be elevated, leukocytes tend to be elevated, and that's all because of the systemic inflammatory cytokine cascade process. We do know that early excision of full thickness burn tissue is the best and most effective method for minimizing bacterial colonization. And the longer that dead tissue stays on the body, the more gram-positive, which is Staph aureus and Streptococcus colonization, will occur. And then what will happen is the gram-negative bugs will come in, and you get Pseudomonas, which is a nice, lovely smell, and then the Proteus mirabilis will colonize. We also know that gram-negative bacteria is associated with a 50% increase in the mortality for burn patients, and that there is a direct correlation with TBSA and the likelihood of colonized infections. So from a systemic perspective, what you tend to do with burn patients is develop resistance to antibiotics, so they're on multiple courses of antibiotics. It's not unusual for large burns in the ICU to go through periods of systemic inflammatory response, acute respiratory distress, and multi-organ system failure, because they're on ventilators, they have central lines, they have Foleys, their skin is open, it's wet, it's got lots of messy wound juices. We've got ventilator support management to help with that. We put them on CRRT, which is continuous renal replacement therapy, and we give them multiple antibiotic regimens. So that concludes my presentation. I know it was rather lengthy. As we say in Hawaii, I am all pal, and I hope you enjoyed and learned a little bit about burns and wound care. Thanks.